We're now going to focus a little bit, and I'm going to focus very narrowly just on that conversation that we're going to have about end-of-life decisions. And so one can talk much wider about palliative care in general, but I wanted to focus, we're just focusing today on consultation skills, and a little bit to look at how we have those conversations and when we're supposed to be having those conversations. And the reality is for us as doctors is that you are encountering death, obviously, in our patients all the time. So either from a sudden death or patient dying within a few hours of you seeing them, but also a lot of patients who are slowly succumbing to illness or elderly patients who are slowly growing weaker over time. But the reality is in our own families, you are going to be encountering death. And quite often, if you've got an elderly parent or grandparent that is getting ill or going through an illness, because you're the doctor in the family, you're going to ask to get involved. And also in ourselves, we're all going to have to face this as well. So this brings up lots of questions. So how often do you counsel patients on death and dying? So how often do doctors actually do this? And the reality is it's been shown that doctors find it very difficult to bring up the topic of death and end-of-life decisions. So if you think about it, when last have you sat down with your patient and helped them write a living will? But how many patients do we have where we actually know that their prognosis is not great, and in the next even 1 year, 2 years, 3 years, they're probably going to possibly going to end up having a stroke, or their heart failure is going to progress, so they're going to go into end-stage renal failure, and yet most of us hope somebody else will bring up the topic. This is for many reasons, partly because as medicine, we're very focused on we're supposed to cure illness and prevent dying, so people almost feel like when you start talking about dying that we have somehow failed our patients. And the way we do it, there's a worry that we're going to upset our patients and that the patient's going to feel we've given up on them if we start opening the conversation about death. What's interesting is that doctors tend to overestimate the patient's prognosis. So most people also assume, no, there's still loads of time to have this conversation. And we find excuses. So we can say we're not quite sure how to do it. We just don't have time. We're not sure what to say. And so quite often subconsciously, we just end up not having the conversation. So we're quite used to bringing in lifestyle modification, for example, as part of our conversations. But we often don't have routine in our mind. Have we had an end-of-life decision? And if you think about it, once somebody's elderly in their 60s, 70s, that anybody should standardly have this conversation. And there's an amazing book that I'm quoting quite a lot in this presentation. It's called Being Mortal by Atul Gawande, an extraordinary book for clinicians about accompanying the dying and elderly. And that actually prompted us to have this conversation with my parents. And not an easy conversation to bring up. If one of you suddenly, if this happened or that happened, what do you want us to do? So I'm going to go through some ethical considerations. So this is an ethics talk. And we're going to talk about why it's good to do it and to have these conversations and the problems of not having these conversations. We'll also spend a little bit of time on autonomy. I'm not going to talk much about justice, but it's also helpful to realize that you don't want to end up putting somebody in ICU on a ventilator that is actually in the last and block that ventilator for somebody else. That person has an undignified death in hospital, but we are also actually preventing the opportunity for somebody else where that ventilator can actually be some use. So when do we have the conversation? So I find there's a lovely palliative screening tool in South Africa that's quite helpful. So the international tools we liked using is something called the SPICT-6, the Supportive and Palliative Care Indicators tool. And then there's something called the Gold Standards Framework Prognostic Indicator Guidance. But in South Africa, they've developed a simple screening tool that can assist us to recognize patients who might have unmet palliative care needs. This is what it's looked like. It's up on the board down in next to the emergency doctor. So just notice here, these are the conditions where you need to think about it. It was during the old days of HIV, which is why HIV is still important, but hopefully we should not get to this point with HIV. But look there, kidney disease, how many patients do we not have with kidney failure, patients with COPD, patients with stroke, patients with dementia, patients with uncontrolled diabetes mellitus, all those very frail elderly patients. And then their step 2 is to look at somebody with this, if they also have now spending in bed more than 50% of the day, or they've had lots of hospital submissions, or they're losing lots of weights, they've had serious falls, they're becoming confused, The patient might even themselves say, we no longer want to have active care for this patient, or you can see this is advancing disease that is deteriorating. And all of these actually are, you're going into palliative care mode. And with all of these patients, this conversation must happen in terms of what are we going to happen when this patient suddenly. So why do we do this? The impact there's a huge impact on the patient's lives themselves just by talking about end of life. So it's actually shown it reduces anxiety and depression. It actually improves symptom management because patients start focusing more on quality of life. Sorry, my computer is faster than I am today. It increases the changes that death will be with dignity, but very important, it's also shown that it reduces the level of trauma and distress in the family. And in 20 to 30% of patients, it actually even lengthens life. So you want to have the conversation with your patient that you hope your doctor will one day have with you, and you want to have it earlier rather than later. So our focus at this stage is about avoiding suffering, strengthening relationships with family and friends, being mentally aware, not being a burden on others, having a sense of life that is complete, and the patient will decide which of these is important. I once had a woman in her late 40s who had bowel cancer. She had 3 children. The youngest was 6 years old. And her decision was she would take chemo and whatever it was, even if it just gave her 2 or 3 extra weeks in her life, because she wanted as long as possible with her children, no matter what her quality of life was like. That might be different for somebody in their 70s or 80s who are going, hold on, I don't want to be sick on chemo for the last 2-3 months of my life. So we have to help people achieve what's most important to them at the end of their lives. And that's an important conversation also that we have to have with the families. So our goal is shifted. It's not to extend life, but to help people live their fullest lives right now. So we're just looking at pain and discomfort, mental awareness. Do they want to get out with a family? What can make their lives easier right now? So what happens if we don't? And it's actually been shown that most people and families are not prepared for that final process of dying. And I've even seen this in doctors. So you will have doctors, your mom's got has had a stroke, the prognosis is very poor, but even doctors will suddenly get caught by surprise when they suddenly in those final stages. It's different when it's your own mom or your own dad versus when you're dealing with a patient. So if we don't have these conversations, you end up having a scenario where people are admitted to hospital where they could have had a peaceful death at home. You end up with terminal patients blocking up beds in internal medicine wards and sitting on ventilations or having IVI nutrition. And all it does is it just lengthens the suffering for both the patient, the family. You end up having a much poorer symptom management, and poorly controlled pain is quite common if you don't have these conversations. And you end up with traumatized family and actually family conflicts about what's happened. And they talk a lot about poor decision-making at the time and real regret. So patients afterwards going, I wish we hadn't taken them to hospital, or I wish it hadn't been like that. So this is a very helpful framework in terms of thinking about the kinds of consultation you're having. So traditionally, old days, we used to have these paternalistic doctor knows best kind of consultations. So you explain to the patient, this is what's wrong with you, and this is what we're going to do. And we've sort of gone into the other direction where a lot of people are just very informative. So they just give the patient lots of information, and now the patient must decide what they want to do. But we actually want to, a bit like when you're selling something to somebody, but we want to look at an interpretive consultation style. You want to explain to the patient, this is what I know, and this is what it means. So your mom has had a stroke. It's a second stroke at the moment, and this means that time is getting short, and we're not, it's very possible that at any moment she could have another stroke. So you want to start having that conversation about what does this mean? What do I know, which the patient might not know, that's going to influence their decision-making as they go along. So we want to establish the following, and these are the sort of important things that goes into a living will as well. We want to know from the patient if they want to be resuscitated if their heart stops. So if you're admitting somebody into hospital, for example, are we going to jump on your chest? Are we going to do something aggressive, like actually tube you and put you on a ventilator? The question of antibiotics is interesting. So if you've got a patient who's got quite advanced dementia, very confused, hardly recognizes anybody in the household, getting very, very frail, we know that dementia has got a much higher mortality, it shortens life, but quite often the way somebody dies is through something like a pneumonia or an infection or a septicemia. It's the natural outcome of that disease process. By giving antibiotics, what we're actually doing is extending life beyond what is natural. So it's one of those, and this kind of conversation to have by the time the patient with severe dementia has antibiotics is impossible. This is a conversation that has to happen very early. Are our focus going to be keeping you at home and keeping you comfortable? And we'll make sure that you have, you don't have too much pain. We'll make sure there's oxygen or whatever is needed, but that there's not an automatic thing that we try and treat every single thing that we are picking up. And now all we're doing is we're giving the patient another few days, potentially, or another month. And then if somebody's unable to eat, are we going to actually put your intravenous feeding or intravenous? So these are difficult conversations that has to happen early. And the question is a little bit, well, how do we even start having this kind of conversation? So again, the breaks that we've actually covered in our Breaking Bad News, we can use that same formula. You can use that same steps, because actually telling somebody that we need to make an end-of-life decision is in itself breaking bad news. So it can be in the context with, we're not thinking it's necessarily going to happen right now, but we need to start thinking and preparing that this disease that you have is actually probably going to be what's going to lead to your demise. So background, very important in terms of end-of-life decisions, is the family must be involved. So with Breaking Bad News, the patient can decide, okay, I just want to, on my own, make all of these decisions. Some patients might independently want to have this discussion with you for a living will. But quite often you have patients who've brought in the family, and now you're there with a patient who's had a stroke and all the family is standing around and they're expecting admission. And it's very important that all of them needs to be part of this conversation. And you need to make sure there's a private and confidential space. The rapport is very important, that you must come over as an ally. If you're already coming over with, we don't have any beds and this might not be the best thing, and then they feel like you're now trying to not admit the patient for your own purposes. You must be very clear to the family that our most important thing is what's going to be best for your mom or your dad here. Also notice it might have to involve also what the patients can or the family can or cannot manage at home. But we're not here to look at the daughter feeling guilty because she's been in Joburg and now she feels something must be done. We have to focus 100% on what's going to be best for that patient. And the family needs to feel that. They need to feel you're on their side and we're sitting together to decide what's going to be best for my mom or dad. Now you want to explore, you want to identify what the patient and the family thinks and expects. Very important, because they've been told various things along the way. And it's kind of fascinating. Quite often you would find, if the patient is able to communicate and is you're able to include them in the conversation, sometimes the patients are much more realistic about the fact that they're busy dying, but the family is still not quite there. So part of it is understanding what everybody in the room thinks is going on. And it's sometimes very helpful for the patient to have a safe space to say, actually, I think this is it, and I'm quite comfortable with it. And quite often the person who's dying accepts it sooner than the family around them. So your announcement is making it now clear that treatment is moving from curative to palliative. So if they've brought in that patient with a stroke lying there and they want admission, you have to be clear that there's nothing medically that we can do that's going to reverse that stroke. So if somebody's at the point now where there isn't any, sometimes there are things we can still do, but if we're at the point where actually this is it, there's nothing more we can do medically, and it's not about saying we're now giving up, it's about saying, listen, our focus is not going to be about reversing the stroke, that medicine can't do, but now our focus is about how to make sure that this patient gets the best and gets what they need in the last days of their life. And again, in terms of the details on the condition, you're going to figure out from the family how much details they need, give them all the information, answer all their questions, but you want to shift that focus in terms of saving his life, extending his life, and start focusing on quality of life. Managing emotions, we discussed this in detail under Breaking Bad News. The same rules apply in being able to recognize and understand and give space for those emotions. And then very important is sitting down and making that plan. So I'm just going to go through 2 or 3 of those in a bit more detail. When you do your exploration, in motivational interviewing, we talk about elicit, provide, elicit. You want to get lots of information. In these kinds of scenarios, there's a few kind of questions you want to ask. And you want to check with the patient, what do you think is going to happen? And sometimes patients either have very strange expectations of what they think is going, or they actually might already be there. Ask them about their worst fears. For some people, having pain is their worst fear. For a lot of elderly people, being a burden is their worst fear. So it's important to start finding out what scares them about this time ahead. And then I like this term when you say to people, if time becomes short, you can say to somebody, we don't know at which point this illness is going to go down, but if time gets short, if you're in that law, what is most important to you? What do you want to see happening? And it's very important to figure out from the patient what that is. How do you want to spend your time if your health worsens? So that's another way of asking the question. If you're suddenly bedridden, for example, what would you like to be doing with that time? Where do you want to be? And this is quite a good question if you're starting to discuss things like life-saving treatments, that's potentially like with cancer treatments, for example. What trade-offs are you willing to make for more time? So quite often when you're offering somebody like a 3rd or 4th line chemo, and chemo has been failing and failing and failing, the oncologist is sometimes thinking, I'm hoping to get another month, 2 months if we're lucky. The patient's thinking this might be the next cure potentially. And that needs to be very clear. I can give you a little bit of extra time. I don't think it's going to be much more than this, but this is what you're going to experience during that time. And the patient needs to decide, is it worth it? Am I willing for that trade-off for that amount of time? And this is very, very important. And this is, I think, which is so frustrating. Because quite often when we're having the conversations, the patient is unable to be part of that conversation. They've arrived, they've had a massive stroke, they might have severe dementia, they might be very confused, and now the family has to make this decision. And now you might have a whole bunch of family members and they all have different ideas of what's supposed to happen, and nobody knows what the patient would have actually wanted. So part of this important part of the conversation is saying, let's get clear what you want. Let's write it down, and who is the person that's going to make decisions for you when you can't make decisions? This is the kind of conversation we should be having with our own parents. Not a pleasant dinner conversation, but one can do it in such a way that and your parents have thought about this, guaranteed. My parents are quite elderly now, they're in their 70s. When you get to that stage, you are wondering and thinking about what you want or what you don't want to see happening. And there are very, very few elderly people who is happy to go on a ventilator, for example. So when you announce it, provide clear and open information, bring that warmth. And a quite a useful thing is, I am worried. So again, if you've got that patient, I'm worried if we admit the patient tonight, they might even pass away this weekend. I'm worried you won't be able to spend that much time with him. I'm worried that this might not be what they would have wanted. So that's a way to start bringing up your concerns about what's going to happen. When you give the patient information, do not lie or whitewash what is happening. So if you are going to send the patient home, don't falsely reassure them. You're going to answer all their questions, and very important, interpret to them what it means. And remember, your different families might also be at different stages of, they might be in terms of denial and anger and acceptance, and you might have to deal with all of that. So your aim with your strategy side is to actually use shared decision to draft a living will. How many are you all too young to have living wills? Those of us who are a bit older, we all have living wills. But you need to actually have that clear, although I guess for all of us, or anybody who has a will probably has to have an attachment to be clear about what happens. If you're on a car accident and you are brain dead, for example, do you want somebody to switch off the ventilator? It becomes a little bit tricky if you've not actually clearly highlighted that. So you want to write down those 5. So you want to summarize the discussion. Okay, this is what we've discussed. This is what we know. And then you want to be very clear. So if you're admitting the patient, in the notes, you're going to write your resuscitation order. Please just don't write, do not resuscitate. It's DNR as this abbreviation. Write discussed with family, do not resuscitate in case of arrest or whatever. And you want to discuss also if you're not going to ventilate or put them on, if you're not going to tube them or put them onto ventilation, that's important in a inpatient setting. If they're going to go home, then you want to talk about things like antibiotics, for example. Are we going to give antibiotics or not? What do we think? And again, this is very helpful to have that conversation with a person early on in their illness. If you are severely if your dementia gets so bad at the time where you no longer even recognizing people and you got an infection, would you want people to treat it and keep you going? What is your choices? And then if the patient gets to the point where they're no longer eating. So most patients, it's different if you have somebody who's got esophageal cancer, for example, but a lot of patients in their last days just becomes very frail and very weak, and they're not hungry. They don't want to eat. They don't feel like eating. And obviously, if one can get fluid in, a little bit of oral fluid or a little bit of just in terms of keeping them comfortable, they don't need to be fed. And that also that decision needs to be made. A very important part of your strategy is to look at the support that needs to happen around this family, not just in terms of the patient. So we have an hospice, St. Bernard's Hospice, and in Mthanzane, they don't have an inpatient facility. So actually, quite often we are trying to expect home care, or that's what you don't actually want your patients to be dying in the G2 or wherever. So St. Bernard's Hospice is great because they visit patients at their homes. They've got very limited funding, so apparently they only take people with cancer, which is frustrating. We had a case recently of an old man who's actually dying with a stroke and all kinds of other things, dementia, etc. But fortunately, he also had prostate cancer, which is not actually the reason why he was dying, but we were able to therefore get him hospice support. So that's one of the frustrations. But that's great if you have. But I think looking really at things like resources like our churches. So a lot of our patients are part of a strong church community. Figure out who the pastors is. Pastors see that as part of their pastoral care, is visiting and supporting a family. And we really need to look at how we use that social capital in our areas. When you send your patient home, make sure there are clear contingency plans. So think through, you can call it, I like this idea, it's called a home comfort pack. But think in terms of all the kinds of things that might happen that means that they don't have to come all the way to hospital. So obviously make sure your pain control is properly sorted out. If you're using something like morphine, if they get quite short of breath, morphine's quite nice for that. If they're getting anxious or freaked out, lorazepam, have metoclopramide available for nausea. Atropine is something that the hospice nurses often, if they get a lot of secretions in the last few hours. Talk them through the different scenarios, when to call the nurse, when to call the ambulance or not. So the family might even say, we can't have the patient dying at home. I can't deal with that. I can't deal with a body at home. I can't deal with this. And so there might even be a decision if the patient gets to that point, the only place to come is an internal medicine ward, not a probe. We don't have a district hospital, for example. But then it also needs to be clear, and there needs to be a clear letter that the patient does not end up sitting in A&E for ages and ending up getting ventilated or something crazy, but that they can go somewhere in a bed where they've got access to their family and can just get their nursing care. And then also just the plan. When the patient dies at home, what do you do? Who do you call? How urgently do you have to call it? It's actually helpful for patients to know that if the patient dies at midnight, some people are quite comfortable to then sit with the patient and do their mourning and their but we have to have these conversations before it happens. So just in summary, it's your responsibility to start the conversation about end-of-life decisions. How many times has a patient started that conversation with you and said, if I start dying, what are my options, right? Does not happen. If you don't bring up the topic, it's not going to have been discussed. And we are all dealing with the fallouts of people arriving here and you're going, this patient should never have come in. If you are having a conversation, say you've got a patient with dementia that's progressing or cancer even that's progressing, this is not a one-off conversation. Every time you see the patient, you need to revisit that living will and revisit those questions. It's also fine if things change. And it's also good, people quite often blank some of it out. So to rethink through it as we go through their illness, and to very much consider that patient's context and culture. So be very careful to not bring too strongly your own ideas of how you think things should happen, There's no right or wrong on how people want to spend the last days of their lives. It has to be their own decisions. What we want to focus on is quality of life, and that's your job. You want to focus on sorting out the constipation. You want to make sure if there's diarrhea that we're managing that well. We want to make sure that they're not in any pain. We want to make sure that short of breath is not a problem. We want to make sure there are no bed sores. That is an essential part of your care of that patient. And it's actually much more important than any of the curative stuff we've been doing up to that side. And we have to take that very seriously as a core part of our job in palliative care. Those are my references. Thank you very much. I was wondering if we just stop the recording.